I am Ed McFarland, and thanks so much for the honor to present our research here today. I'd like to recognize the co-authors who also did a lot of the work and helped put this all together. There's nothing to disclose for this presentation. Several studies of clinical results after two-stage revision for prosthetic shoulder infections have been reported. Oddly enough, there are several systematic reviews that suggest that the results are the same or even better perhaps with one-stage revision, but the tradition in our country has been two-stage revision. None of the studies previously published have had a minimum of 5-year follow-up. So the goals of this study were to determine the reinfection rate, pain relief, and functional outcomes of two-stage revision of PSI and a minimum follow-up of 5 years. Our secondary aim, though, was to also evaluate the application of the new guidelines from the International Consensus Meeting in Philadelphia in 2018, who came up with criteria for the diagnosis of PSI in this cohort. Included in the study were patients with infection who had shoulder arthroplasties with a two-stage revision between 2005 and 2014 by one surgeon. All were revised to a reverse shoulder arthroplasty at the second stage to an implant that had a lateralized glenosphere, inlay humeral tray, and a 135-degree neck shaft angle. Seventeen patients had a minimum follow-up of 5 years, and most of them were male. Failure was defined as revision of the prosthesis or a recurrent infection. We also kept track of other complications such as dislocations, fractures, or notching. The results, about 3/4 of them had an elevated CRP. ERCR was less helpful. We had a successful aspiration in 16 patients, but obtained positive cultures in only 31%. Of those who had aspiration, only 6 had a white blood cell count greater than 3,000. There was humeral loosening in 18%, 71% grew intraoperative organisms, and of these, 50% were C. acnes, which is sort of the current trend. In terms of histology, at the time of surgery, 100% of the patients had greater than 5 white blood cells per high-powered field. When we applied the ICM criteria, basically for definitive or definite joint infection, 10 patients or 59% met criteria. Those criteria are presence of a sinus tract, a gross intra-articular pus, or 2 positive tissue cultures with similar or the same virulent organism. The other criteria for probable or impossible and unlikely are set up with a set of criteria shown in the table on the right. Those are all weighted and then they're added up to fall into probable, which is greater than 6, possible is 6 or greater without identifying the organism, and then of course unlikely. There were recurrent infections in 3 patients. These occurred mostly after 1 year, with 18% of them, or 3 of them, by 5 years. Other complications included 4 periprosthetic fractures, which were usually intra-articular, greater tuberosity fractures, 1 spacer fracture, and 1 dislocation. All patients had both statistical and clinically significant improvements in their patient-reported outcomes, including the VAS for pain, ASES, SST, and the WOOS. Most patients had statistically significant improvement in elevation, but not so much in rotations. In conclusion, then, we found that 2-stage revisions had a reinfection rate of around 18% at midterm follow-up. Patients who remained infection-free did have clinical improvement, not only in their pain relief, but in their PROs and function. So we recommend that 5-year follow-up be recommended for future studies of PSI. Also, the ICM criteria right now are diagnostic only, and you need intraoperative histology and cultures to make the final diagnosis. And these need to be connected with therapeutic pathways in the future so that we can make sure that they have clinical utility.